Welcome to this video on vasectomy reversal. My goal here for this video is to give you a little bit of insight to how we actually do the operation and we reconnect the tubes at the time of a vasectomy reversal. So starting off, we know that there's a site of blockage in the tube that carries the sperm. This is called the Vas Deferens. If you look at the picture here, you can see that I've marked this site of blockage as a blank space. Essentially, we make a vertical incision in the scrotum through the skin so that we can access this segment of the tube. After we isolate the tube, we cut the tube on either side of the vasectomy site so we have a fresh end. Essentially, this ensures that it's healthy, it has good blood supply to it, and the opening of it is completely patent and there's no more blockage. Then typically what we'll do is I like to use a microdot technique, which I learned from my mentor, Dr. Mark Goldstein. And essentially what we do here is we draw these tiny little dots that mark out where we're going to place the sutures. This separates the planning from the executing part and allows us to ensure that we have really precise placement of these stitches for a very precise connection. So if you look at the left-hand photo here, there are 6 dots marking where we're planning our initial layer of sutures. The middle photo here demonstrates 3 stitches going in, connecting the left side of the tube compared to the right side of the tube. And the stitches are going through each of these little dots. We then tie these stitches together to bring the left and the right sides of the tube together. After these are tied down, we'll typically put another second or third layer of stitches in through the muscle part or the meaty part of the tube, which actually gives it its strength in the reconnection. We'll then flip the tube to the other side and perform the second half of the reconnection in the exact same manner. What are some of the really important factors that we have to consider when we want our connection to be a success? The first thing is making sure that we have really accurate and precise approximation of the 2 sides of the tube, meaning that the inside of the circles are lined up very precisely so that they remain open, and the outside is very precise so there's no leakage and there's good strength. That brings us to the second point, a leak-proof anastomosis, meaning a leak-proof connection. Essentially here we have the inner side of the tube, the hollow portion of the straw, if you'd like to think of it that way, is being really well connected, and all the fluid in the sperm that travels through this open space cannot leak out through this connection to the outside. Part of the thing that helps here is also having good strength layer on the outside of the tube with precise and equal spaced positioning of these sutures. We need to ensure that it's not on any tension so that the tissue can heal nicely, that there's a good blood supply, again supporting the good healing of the tissue, that the edges of the tube that we've cut back are healthy and have the good blood supply. And we're using very delicate handling of the tissue so that there's no micro traumas that we don't detect at the time. These are some of the very important things that we're always considering when we're making the connection and we want to have a good, successful result. So what is the gold standard? Well, there's the Goldstein microdot technique. This was Dr. Mark Goldstein from Weill Cornell. He published a paper of 194 consecutive cases that had a 99.5% patency rate. And what he did here for the innovation was using those microdots that you saw on the previous images that essentially separate the planning from the execution of placing the stitches through. What this really does is it allows you to be very precise and consistent with the spacing of the sutures so that everything comes together very nicely and there's a much lower chance of having a leak where a leak can result in the ends of the tube kind of getting pushed apart and a blockage ensuing. The Mark's angled microdot technique was an extrapolation on the Goldstein technique, and essentially the difference here was that they did an angle cut so the surface area of the tubes was slightly larger. Dr. Marks had excellent results as well, quoting about a 99.5% patency rate with the angle technique and a 95.7% patency rate with the straight technique. And Of note here, the average concentration of the sperm was between 38 and 49 million per cc, which is well within the normal range, and the motility was just under the normal range at 38.9%, where we define normal as about 40%. These results are excellent and really reiterates the importance of the microdot technique and very precise planning and placement of the sutures and using multiple layers to get the two sides of the tube together nicely. If we look at the more generic literature outcomes of all types of vasectomy reversals, single layer, multi-layer, with the microdots, without the microdots, the success rate's about 89%, and clinical pregnancy rates are approximately 73%. However, it's really important to note here that your specific potential outcomes have a lot of variables that go into it, so it's best to have a face-to-face conversation with your treating surgeon to get a good sense of what you can expect for your success rates and your clinical pregnancy rates. So in summary, the vasectomy reversal techniques that have the highest published success rates adhere to optimal intraoperative decision-making, use very precise suture placement, and use the microdot technique. These are performed under a high-powered operating microscope and should be performed by a male reproductive microsurgeon that has training and experience in this in hopes of getting the best results for you. Thanks for watching this video. If you'd like more information, feel free to visit my website or the YouTube channel listed here and my Twitter handle below. Thanks very much.